Hello, good afternoon. Delighted to be here, back in Britain, and back here again. I've been away for a few years in the United States, and it's been a while since I've joined you at your meetings. So my job today is to discuss the treatment of ocular melanoma. Quite a few topics to discuss, so I'll go right into it. It's really important to differentiate intraocular melanomas from conjunctival melanomas. The conjunctival melanomas are like melanomas rising in the skin, and uveal melanomas have a totally different genetic pathway and behave totally differently. And even in the eye, they behave differently from each other. The tumors at the back of the eye, in the choroid, cause different symptoms from those in the ciliary body and in the iris. So in the choroid, uveal melanomas tend to, first they cause flashing lights and a blind spot to one side. And then when the retina becomes detached over the fovea, the central part of the vision, they notice distorted vision or a blurred vision. And if the tumor is allowed to get very big, then the vision gets worse and worse. And eventually, you get inflammation in the eye. You get new veins growing where they shouldn't be, that clog up the gutters, high pressure, and you get a painful red eye. And with regards to ciliary body tumors near the front of the eye, they have the same effects, but they also press on the lens to cause first astigmatism and then cataract. And over there is a picture of somebody who had a cataract caused by a melanoma, which wasn't detected until after the cataract operation. And ciliary body tumors also grow towards the front of the eye into what's known as the anterior chamber, and they behave like iris melanomas. The iris melanomas develop on the colored part of the eye, and if they grow diffusely, they can clog up the gutter over there. The gutter is where the fluid leaks from the eye, and if that gets blocked, the pressure goes up, you get a painful eye from glaucoma. So, with regards to conjunctival tumors, the problems they cause, first there's a visible tumor, and if they block the tear duct, you get a watery eye. If they grow behind the eye, then they push the eye forwards. Usually they're treated long before that happens. I'll speak about this later. I'm going to speak about metastasis. That's the other thing that these things cause. Metastatic disease, when they spread from the eye into the blood circulation around the body, and then they settle the liver and other organs where they form new tumors that cause metastatic disease, which is usually fatal. And the metastatic disease tends to occur almost exclusively in patients whose tumor shows chromosome 3 loss. And this mutation tends to occur in the choroid, in the melanocytes in the eye. And that's why it's not inherited, because it's miles away from the reproductive organs. It's just in the eye. And if there is chromosome 3 loss, the tumor develops the capacity to escape from the eye, float around the circulatory system, and come out in the liver and other organs to form cancer there. And it's not just loss of chromosome 3 that is associated with this. There's all sorts of other mutations that occur. We're discovering new mutations every year. Some actually reduce the risk of metastasis, and others increase the risk. And the really bad one is the BAP1 mutation, which usually occurs in the tumor, but very, very rarely is inherited, and runs in families that also get kidney cancer, lung cancer, mesothelioma, skin cancer, and so on. So in the iris, the chances of metastatic spread are much less than uveal melanomas. A lot depends on the way the tumor is growing. If it's forming a nodule, the prognosis is good. But if it's spreading in a diffuse fashion, as you can see on the right, then that's associated with much higher risk of metastatic disease. In the conjunctiva, there's a big difference there in that you have lymph channels that go to the lymph glands in the neck and in front of the ear. So some of the metastases spread through those lymph channels. You can get glands in the neck, which almost never happen with intraocular melanomas. And other tumors spread through the blood vessels directly to the heart and from there to other organs. And the bigger the tumor, the greater the risk of spread elsewhere. But I'll come to that later again. So why do we treat uveal melanomas? Well, all ocular melanomas. Obviously to prevent metastatic spread, but also to prevent blindness, if we can do that, and to prevent the eye from becoming inflamed, unsightly, painful, and causing lots of discomfort and facial disfigurement. So there are lots of reasons for treating these tumors. So looking at the intraocular melanomas, uveal melanomas, does treatment actually prevent metastatic spread? Well, obviously not in all patients, because almost 5 out of 10 patients develop metastasis despite successful treatment of the ocular tumor. And that's because the tumor has spread long before the patient first presents to us. So a lot depends on the, as I said, on the mutation in chromosome 3. And this shows the frequency of chromosome 3 loss, monosomy 3, according to the size of the tumor. The bigger the tumor, the higher the prevalence of monosomy 3. But even in small tumors, almost 1 in 2 small tumors, only 10 millimeters in diameter, have that mutation, that dangerous mutation. So if that mutation is absent, this tumor is just dangerous for the eye. But if that mutation is present, then the tumor is very life-threatening. And the bigger the tumor, the more life-threatening it is. And then that graph on the right shows the chances of developing metastatic disease according to the size of the tumor. The bigger the tumor, the worse the prognosis. But the prevalence of the bad mutation is higher than the rate of metastatic disease. And to me, that suggests that the ocular treatment does prevent metastasis in some patients, especially if the tumor is small when it is treated. So basically, I think there are 3 groups of patients. Those whose tumor has spread very early, so treatment doesn't make any difference. Those whose tumor will never spread, even if you don't treat it, so treatment doesn't make any difference. And then there's some patients where the timing of the treatment is really important. So it'd be nice to do, well, not nice, but if it was ethically possible, it would be good to do a research project to treat some patients straight away and to delay the treatment of other patients and to compare the 2 groups. But I don't think many of you would like to have your treatment delayed. But in a way, this experiment is happening by itself without us doing it. Because most patients present around the age of 60. But there are some who present at a younger age, some who present at an older age. And according to my research a few years ago, older patients tend to have bigger tumors. So, to me, that suggests either that the tumor grows more quickly in older people, or the tumor has been growing for a longer time, and that's why it's bigger. But it's not just that the tumor is bigger, but older patients tend to have a more aggressive tumor. They're more likely to have chromosome 3 loss in their tumor. They're more likely to have a life-threatening tumor. To me, that means that because the tumor has been growing for a longer period, it had a longer time to develop one mutation after another, and it's like rolling dice as to which mutation occurs first. And so there's more of a chance of that life-threatening mutation occurring. So to me, this means that we should treat these patients, these tumors, as early as possible. And here's a patient we learned a lot from. This patient was being looked after at a time when most people believed that ocular treatment never made any difference to the chances of survival. And there was a small tumor there. We weren't sure if it was a melanoma or not. It was a bit bigger than usual. She had diabetes. Radiotherapy would have made the eye inflamed and painful. And she might also have developed loss of vision in the other eye from her diabetes. So we just watched her. And then suddenly the tumor grew very quickly, and we removed the eye. And we found that in the old part of the tumor, it was the disomy 3 good melanoma that was not life-threatening. And in the new part of the tumor that had grown very quickly, very recently, there was a monosomy 3. There was a dangerous mutation. And so, to me, this shows that just like other cancers, lymphoma and so on, you can have a cancer that's not very malignant, just grumbling along, and then something happens and it explodes and becomes much more dangerous, much more aggressive. And that's what happened to this patient. With conjunctival tumors, a lot depends on where the tumor occurs. My studies show that the closer the tumor is to the nose, the greater the risk of metastasis. And also, if the conjunctiva, if the tumor grows away from the white of the eye, underneath the eyelids, or on the caruncle, the fleshy part here, that's more dangerous. And in different parts of the conjunctiva, you get different mutations in the melanoma, depending on how much light that part of the conjunctiva receives. So that on the white of the eye, there's lots of light, and underneath the eyelids, there's less light, and there's different genetic profiles according to where it arises. So now that we've spoken about why we treat ocular melanomas, I'd like to speak about how we treat them. In most centers, the first choice of treatment is radiotherapy. Just drop an atom bomb on the tumor, and it dies. The problem is that the dose needed to kill the tumor is higher than the dose needed to kill the eye. So we've got to focus the radiation just on the tumor, avoiding the optic nerve and the other ocular structures so that we can save the eye. And one way to do this is with a radioactive implant known as a plaque, because it's got the shape of a plaque, a bit like a 5p coin. And that gives radiation for a short distance. With the ruthenium plaque, gives beta radiation. It's only good for tumors up to 5 millimeters thick. And so that's good because you can give a high dose of radiation to the tumor while avoiding the optic nerve and other structures, unless the tumor is actually touching those structures. In the States and other countries, they prefer iodine radiation, which has the advantage of having a greater range, so you can treat bigger tumors. But the problem with that is that you give a bigger dose to optic nerve, fovea, so you get more side effects, more loss of vision, more cataract, more problems. Another way to focus the radiation is there's a big gun known as a cyclotron. And it fires these little bullets known as protons. And strangely enough, the protons don't cause any harm when they're moving, but then when they stop, they release lots of energy, which damages all the atoms and molecules round about and the genes nearby. That's why it's called ionizing radiation, and kills the cells in that area. And the nice thing about proton beam radiotherapy is the way that it can be focused. It stops just where you want it to. It doesn't scatter much to one side, and that's the advantage of proton beam. The disadvantage of proton beam is that it does damage the superficial tissues it passes through to some extent. But you don't need to worry about brain or anything like that. Then there's surgical resection of the tumor, and there's different techniques. One technique is to cut the tumor into little bits and suck up all the bits through a little vacuum cleaner, and then give laser treatment in case you've left any behind, and then perhaps give radiation treatment to make sure you've got it all. And in some patients where the tumor is right next to the nerve and the radiation would have damaged the nerve and the patient relies on the vision and so on, then that's the only way to save the vision in that patient. Obviously very controversial, because people think that you cut the tumor into little bits and they're going to scatter around the rest of the body and kill the patient. But that's not what happens. These tumors don't behave like dandelion seeds. It's not a physical, passive kind of spread. It can occur locally on the surface of the eye, rarely, very rarely. That's called seeding. But the metastatic process is a very complex biological phenomenon, like bee colonies. You know, the bee colony swarms when the queen bee decides to move somewhere else, whether or not anybody goes near it. Same with uveal melanomas. So our survival studies show that the chance of surviving are as good after this operation as after removal of the eye. And then there's the trapdoor operation, local resection. We make a big trapdoor in the eye, cut around the tumor, and go underneath the retina and take the tumor out without damaging retina, and then close the trapdoor again. It's a very difficult operation. You need to lower the blood pressure. It takes a few hours to do. The patient needs to be fit. It's like a really complex game with lots of pitfalls, and you've got to have a lot of experience to keep out of trouble and to get a good result. And so that's why not many people do this operation. But it's useful for tumors where it's the only chance there is of saving the eye, and if it's important to save the eye and the vision, and the patient accepts that if it works, great. If not, they haven't lost anything. They would have had the eye removed in any case. Then there's laser treatment. It's not as reliable as radiotherapy, and so it's only used after radiation as a rule. But here's a patient on the right. It's a patient who saw her optician in the United States. I was treating her when I was there in San Francisco. And the back of the eye was normal in 2012. And in 2017, the optometrist noticed something like a freckle, which wasn't there before. To me, even though it was a very, very small tumor, it was a melanoma because it had grown several hundredfold in a few years. Nevi don't do that. They don't just come out of nowhere, except in very early life. So with a tiny tumor like that, I felt confident that we could eradicate it with laser treatment, hot laser treatment, where we gently cook the tumor. Otherwise, I would prefer radiotherapy. Then there's photodynamic therapy, where we treat with cold laser. And what this laser does, it's got a special wavelength. First, you inject something into the arm, a drug into the arm. And then a few seconds later, you shine light into the eye of a special wavelength. It's an invisible light. we can't see it. And that activates the drug, which damages the cells round about and kills the tumor. And that's known as photodynamic therapy. It's used an awful lot in old patients who have age-related macular degeneration and leaking veins, and it's used for that quite a bit. Then there's a new technique that you're probably going to hear more of, aura treatment, where instead of injecting the drug into the arm and waiting for it to reach the eye, it's injected into the vitreous gel, and then it passes through the retina, concentrates in the tumor, and then you shine the light, and that shrinks the tumor. And this is still being investigated, but there are some encouraging results there. With iris tumors, you can treat with radiotherapy, which doesn't make a big hole on the front of the eye. You can even treat the whole of the front of the eye. And if the tumor is small and to one side, then you can make a little trapdoor and cut the tumor away there. Some people who don't have access to proton beam treat these tumors with a radioactive plaque. And good patients, you get good results. And then there's multimodal therapy, where you combine lots of different treatments. For instance, there was a patient with a really big tumor in the right eye, he had a lazy eye on the other side. So I did a trapdoor operation. But then I deliberately left a bit behind, because if I tried to remove it all surgically, I would have made his eye blind. And I treated that with radiotherapy. And I deliberately left a bit untreated, because otherwise I would have destroyed the nerve. And I treated that with laser. And many years later, he still had 6/6, 20/20 vision in that eye. So people argue about which treatment is best. We've really got to select treatment according to the tumor and the patient. And increasingly, we're combining different treatments. And then there's enucleation, where we remove the eye, we bury a ball instead of it, and then after a few weeks, we fit an artificial eye. And for many patients, that's by far the best treatment. And our quality of life studies show that they're as happy as those who've had a radiotherapy or something else once they adjust after a few weeks or months. Unless, of course, they've got loss of vision in the other eye. They're probably happier than patients who've had radiotherapy with lots and lots of complications, especially if they've had to have the eye removed after years of suffering. And then there's this new drug here, developed originally in the University of Oxford, where I'm working 2 days a week, and being developed by Immunocore, and I'm a part-time consultant at Immunocore. And it acts like a matchmaker. With one hand, it gets the melanoma cell. The other hand, it gets the killer T lymphocyte, the soldiers of the blood, brings them together. You get a kiss of death. Poisons coming from the killer cell into the tumor cell, kills the tumor. And the results have been very, very encouraging over the past few years. And so that probably what I think will happen with this drug and with other drugs that come along in the future, God knows what's going to come along, it'll be like retinoblastomas. The way we treat retinoblastomas, we first shrink the tumor with chemotherapy, systemic chemotherapy, or intraarterial chemotherapy. And when the tumor is small, then we give the local treatment, the laser treatment or whatever. Because if we try doing that with a big tumor, it just won't work. With conjunctival tumors, we treat with chemotherapy, drops, or we remove the tumor surgically, and then we give radiotherapy afterwards. And so with all these different kinds of melanoma, we need to select the treatment according to the size of the tumor and the location and the patient's feelings. And this shows the chances of saving the eye according to different risk factors. And the worse the risk factors, the greater the likelihood of immediate enucleation. And what we want to see is a straight line here. Because a straight line means that when we've tried to save the eye, we've done so successfully. And the more of a slope there is, the more we've tried to save the eye and failed. And as you can see, by looking at the tumor size, location, distance from the nerve, and so on, we know when we're going to succeed, and we know when we're less likely to succeed. We share that with the patient in a consensual kind of way, and then we go accordingly. On the right there, you can see a melanoma touching the nerve. Some patients would want to have the eye treated with radiotherapy, come what may, even though it's going to cause blindness and perhaps a painful eye. With other patients, they just want to have the eye removed and be done with it. And this week I saw this patient just a few days ago at Moorfields, and he was delighted. He had his eye removed, no problems. He recovered very quickly, and problem solved as far as the eye is concerned. This shows the results of a quality of life study we performed in Liverpool with Laura Hope Stone and others, showing the blue, I think, is radiotherapy, and the red is enucleation. And those two dotted lines show the normal and the American normal quality of life in the normal population. And it shows that the quality of life in patients who've had treatment for ocular melanoma is about the same as in the general population. Just as Laura Hope Stone said, it's hard to believe, but that's what the data show. There's a bit of a dip with regards to the emotional well-being because of fears about the future, which is what was discussed just a few minutes ago. Side effects of treatment, well, with radiotherapy, you can get eyelid damage, causing a dry eye or a blocked tear duct, cosmetic defects. If the tumor is near the nerve dies, you get total loss of vision, perhaps new veins, high pressure, and quite a lot of these tumors, after the irradiation, leak fluid. I call it a toxic tumor, and that causes the retina to become waterlogged with blurred vision. And here's a patient who had that problem. The retina became detached. Then we treated her with Avastin, PDT, nothing worked. Then we treated her with a hot laser, shriveled up the veins in the tumor, problem solved. And this is the first patient from whom I learned about this toxic tumor way back in 1987. She had lots of yellow exudates coming from the irradiated tumor. The obvious thing to do was to remove it, so I removed it, and she did very well indeed. And here's a patient with total retinal detachment from a toxic tumor after radiotherapy in her only seeing eye. The other eye was totally blind since birth. Removed the irradiated tumor, problem solved. With surgical resection, the main problems are leaving a bit of tumor behind. That's why we usually combine it with radiotherapy. And if you damage the retina and make a hole in it, the water from the vitreous leaks through the hole, and you get a retinal detachment. Very rarely you get seeds on the front of the eye that might need some freezing treatment or removal. Those are the main problems with that. But the chance of survival, according to our statistics, are the same with these procedures, these resection procedures, as after enucleation. Laser treatment, here's a tumor that was treated with laser in the 1980s. And there's a tumor that's grown out of the scar because it survived the laser. That's why we try to avoid laser. With conjunctival tumors, we treat with these chemotherapy drops. They're very toxic drops. They cause swelling of the conjunctiva, irritation of the eye, swollen red eyelids, perhaps blocked tear ducts. Usually these things settle down, except sometimes the blocked tear ducts. So does tumor recurrence cause metastasis? If you fail to kill the tumor first time, what happens? Well, the chance of survival diminish. They're lower in patients whose tumor comes back after radiotherapy. And nobody knows for sure whether it's because the tumor was more aggressive in the first place, so that it already spread before the recurrence occurred, or whether the continued growth of the tumor gave more time for the tumor to spread. There's a patient treated in Scandinavia with a plaque. A tumor came back. We removed the tumor, kept her vision because it was her only eye, and then she died some time later. Was it the recurrence that killed her, or was it just a bad tumor, which is why it recurred in the first place? Well, she died a year after her radiotherapy. Yeah, 2005-2006. It's estimated it takes about 8 years for the spread to become symptomatic. So this would suggest that the metastases were already present when she first had her radiotherapy. After conjunctival tumors, we see quite a few patients where a general ophthalmologist has taken out a piece of the tumor to find out what it is. And those patients tend to behave, their tumor tends to behave much more aggressively than the rest of the patients. So that's bad news. And when patients have their tumor missed by their optometrist, so how can we improve our chances? One is early detection. And we did a study on 2,500 patients years ago, and we showed that patients who told us that the tumor was missed by their optometrist were much more likely to lose the eye, to lose vision, and so on, than the ones whose tumor was detected straight away. Early diagnosis. Quite a few melanomas are mistaken for moles, and so they're left untreated, even though they've been found for years. And there are certain signs that we recognize that help us distinguish melanomas from moles. And I've devised mnemonic moles to help optometrists remember these signs. The best way you can help yourself is with knowledge. Knowledge is power. You can make good decisions. You know what's best for you if you know what's available. And that's why we try to share as much information with you as possible. And I have for many years given patients recordings of the conversation, except now that it's become more difficult, we're not allowed to email recordings. So I ask patients if they've got a smartphone, and if they have, I ask them to switch it on and to record what we've said, and that really improves things. One thing I did when I was in the United States was to devise a Bill of Rights for patients, because we did a study, a survey of patients from across the United States. We found out what made them unhappy, what made them happy. And they were very upset when they weren't given enough information to make an informed decision. They're upset when they weren't given emotional support, upset when they weren't told about treatments available elsewhere. And so on the website of the UCSF, I devised this Bill of Rights. And if you know your rights, then you get perhaps better care. And then emotional support from family, friends, health psychologists, as you've heard, really helps. And the psychologist in the United States was really keen on encouraging patients to appreciate their assets, things that help them get better, to help them appreciate their family, their health, and all these things. And now we've got organizations like Ocular UK providing support. There's different organizations, so really very valuable. So we've covered all these things, and hopefully, a little bit more about the treatment of ocular melanomas. I've got to say a few words about biopsy. Why do we biopsy? That's what the question I've been asked. We biopsy to establish a diagnosis. If in a fraction of a second I can't see what a tumor is, biopsy. In other hospitals, they do scans and other things, but different people do things differently. If I can do a biopsy when I'm not sure, it cuts a long story short. If it's a metastasis spreading to the eye from somewhere else, then the biopsy can help show where it's come from, whether it's come from breast or lung or whatever. A biopsy can help distinguish a nevus from a melanoma. Should we watch a tumor? Is it safe to watch a tumor? What if we watch a tumor and it's a melanoma? what if we make the eye blind and it's a benign mole? So one way of resolving this dilemma is to take a sample. And it's possible for an expert surgeon to sample tumors less than 1 millimeter thick, as in this case here. And then, as you all know, biopsy is useful to see if there's any dangerous mutations. And if there are dangerous mutations, then of course the risk of metastasis is much higher than if those mutations are not found. And there are different ways of analyzing tumors in the laboratory. You look at the shape of the cells, how rapidly they're multiplying. You can use special stains. And there's recently a special stain that identifies BAP1 loss, which is associated with metastasis. And then there's different genetic tests, such as FISH. You don't need to know all the small print. FISH, but it only tests a few genes, or MLPA, which is used in Liverpool, which tests 30 genes, 13 of which are on chromosome 3. In the States, they use gene expression profiling, which is a little bit like a black box, good, bad, and ugly in between. And then at UCSF, we developed, Boris Bastian developed a kit for different cancers looking at 500 genes, including all the important uveal melanoma genes, and that's proved to be very valuable. But it's not enough just to identify which tumors are life-threatening. It's also useful to know, to have some idea as to when the metastasis is likely to become symptomatic. And that depends on the size of the tumor, the cell type, the mitotic count, and so on. So it's good to have statistics. And in Liverpool, we developed this tool available online to do that. Different biopsy methods. You can put a fine needle into the tumor, or you can make a little trapdoor and cut a little piece out, or you can remove the whole tumor. That's a little biopsy being done of a very thin tumor with a little vacuum cleaner known as a vitrector. Just go in and out through the retina and get a sample of cells, and then you can tell whether it's a melanoma or not, or else you can go from the outside of the eye. There are complications. You can get seeding on the front of the eye. You can get hemorrhage in the eye that can cause lots of problems. Whereas the sample can be inadequate. You do a big operation, it turns out you're left without any answers. Or the genetic test might be one that's insensitive, or a part of the tumor might be less malignant than the other part, and if you sample the wrong part of the tumor, it's a bit of luck involved, you might get a false prognosis. But now we're hearing more about liquid biopsies. Here's a patient I treated in California with a metastasis from lung, who's getting one kind of therapy, systemic therapy, but from a blood sample, they were able to find some of the tumor cells, find the mutations, and then they said, oh, we're giving the wrong drug. We have to give a different kind of treatment because of the mutations that were found in the blood sample. And that's what I think is going to happen with ocular melanomas. So biopsy is a double-edged sword. You can cause lots of harm to the eye. You can harm the patient's feelings if you don't do this with pre-test counseling, post-test counseling, support afterwards, good information, all the rest of it. But then it can be very useful it reassures patients with a good prognosis. And what I've learned from my patients is that even though it's been difficult to receive bad news, on the whole, patients have felt empowered knowing that the tumor is life-threatening and has helped prepare for any eventuality. So that's my short talk on biopsy as well. And thank you very much for your invitation. Thanks for listening to me. I hope I have answered some of your questions regarding treatment of ocular melanoma and biopsy. Thank you.
Thank you, Bertil. It's all really useful information. I think we've got quite a few questions for you.
Oh.
So well, we're going to see them shortly. So I think if you could answer what you're able to sort of fairly quickly, and then if we can come back to you.
very rarely appear anywhere else before they first appear in the liver. Do they go exclusively to the liver? It looks like it, but when patients survive liver tumors, because they've had treatment and so on, and live long enough, then the tumors in other parts of the body tend to appear. So I suspect, and I'm not an oncologist, you should ask this question to Peter Schlosserek later on, I suspect that they just happen to grow quickly, more quickly in the liver than elsewhere. And that's important because if you give a treatment that affects the whole body, then hopefully you're not just killing the tumors that you see in the liver, but also the tumors that you don't see in other parts of the body because they haven't yet become large enough. How many times can you have plaque treatment? Well, it depends how much you can avoid the radiation to the other tumors. You can repeat plaque treatment twice, maybe 3 times, and even proton beam, as long as the tumor is not near the nerve. If the tumor is near the nerve, of course, if you repeat the treatment, the nerve gets double the dose, and then the eye goes blind. Why is proton beam not offered at all major hospitals? There's only one, well, until recently, well, at the moment, there's only one proton beam for ocular tumors in Britain. And there's 2 in France. I think there's 1 in Germany. And there's 1 in Italy. There's going to be 2. I think recently there have been 2, maybe 3. In the States, they're proliferating. Until recently, there were about 3 or 4, and now there's more. So patients have to travel an awful long way for proton beam treatment. And if you can get this as good results with a plaque, well, why not treat with a plaque? I've always had used plaque as a first choice. It doesn't damage the eyelids, and the patient doesn't need to travel. It's all done in a week, end of story. With proton beam, they first got to have an operation to put in markers. A few weeks later, they need to go to Clatterbridge for simulation. A few weeks after that, it's 5 days having the treatment. Much more difficult. So if you can treat with a plaque, fine. So I've tended to reserve proton beam for patients where I couldn't get a good result with a plaque. And there have been patients where I've said to them, look, I'm not sure if I can put a plaque in the right place. I'll give it a try. If I'm not happy with where the template is, a dummy plaque, we do a dress rehearsal, a dummy plaque, so we don't irradiate ourselves. Then we take out the dummy, put in the real thing. If I'm not happy, I'll take out the dummy plaque, and instead of putting in a radioactive plaque, we'll put in markers for proton beam, and that's what you'll have. And that's worked very well. I was not offered biopsy. Right. When I started doing genetic typing in 1997, as far as I know, nobody was doing it as a routine service to patients. And I had to look at the guidelines for HIV testing in Canada, Canadian guidelines. Because when you give patients bad news, you can't just give bad news or even good news without doing it properly. So you've got to first make sure that the patient understands the implications before you do the test, before you give the result, after you give the result, all these things. And also, it's quite an invasive procedure with risks to the eye and so on, retinal detachment, hemorrhage, infection. And so you don't want to do that unless there's a good chance that it's going to work. So first of all, you need to have the surgical expertise to get a big enough sample. And so for some surgeons, they can only guarantee that with big tumors. And then with more and more experience, they become better and better at doing it with smaller and smaller tumors. But then you also need to have a laboratory that can handle these tiny samples. Not just physically, but that also have the technology to use the most sensitive genetic techniques. Because there's nothing worse than giving a patient a good prognosis and then they get metastasis. That's terrible. It's not only for the patient, but also for other patients because they lose confidence in the system. And so one of the main benefits of doing genetic testing is to reassure patients that they've got a good prognosis. And if patients don't believe that, then a lot of it is perhaps a waste of time to some extent. But then there's the benefits that patients can get entered into clinical trials of systemic therapy, they get more intensive screening, and so on. I don't know why the eye is still painful 3 years after plaque treatment. Either there's a high pressure, or there's problems in the front of the eye, or those are the main reasons: inflammation in the eye, high pressure, irritation on the front of the eye. But some patients, very rarely, you get a type of neuralgia, and there's no reason. You can't explain it. The eye looks perfectly okay. So the simple answer is there's a pinched nerve somewhere. Perhaps there is, perhaps there isn't, but it's a sort of logical kind of explanation. And I send those patients to a pain clinic, and they get the same kind of treatment as neuralgia in other parts of the body. There are people working on a blood test to liquid biopsy to try and detect metastases before they are visible in scans. And I'm confident that they will come quite soon. In the meantime, all we can do, the best we can do, is to see how the tumor is thinking. And the way to do that is to look at the mutations. Surveillance scan, ultrasound MRI. This is a very hot topic, politically and otherwise. I'll leave it to the oncologist to answer that. Because I really depend on their advice. I don't treat the liver, and they don't treat the eye. And there are some really clever ophthalmologists who say, like Professor Kivela in Finland, whose expertise and I really, really respect, is one of the people I listen to very carefully. And he says that ultrasonography is just as valuable as MRI. And others disagree. So it's still something under debate. Yeah, stereotactic radiotherapy is where you aim a beam of radiation from lots of different directions, either at the same time or one direction after another. And so the tumor gets a high dose and everywhere else gets a low dose. That tends to be used in situations where there isn't a proton beam, more and more. And the radiation doesn't seem to be focused as precisely as proton beam, but I'm hearing of good results with that in patients where it's selected carefully, where it's not near the nerve, and so on. Right. Well, the percentage of plaque failure depends very much on the tumor and on the surgeon. The bigger the tumor, the greater the chance of it having invisible roots that are longer than usual, so the tips of the roots might survive. The more awkward the location, the more difficult it is to put the plaque in the right place. That's why sometimes I give up and just treat with proton beam. And it depends on the expertise of the surgeon. If you've got somebody, like everything else, cataract surgery, everything, you've got somebody who does it all the time, several times a week, you get good results. If there's somebody who does it just once a year, then it's a different story. In Britain, we're lucky that we've only got 3 centers here in order to prevent expertise being diluted. And so the surgeons who operate in Britain tend to do lots of these operations. But in many other places, plaque treatment is administered not by ocular oncologists, but by retinal surgeons. And if you've got a team of 10 surgeons and they divvy it up between them in a whole year, you might get somebody doing only a few a year. or if it's in a small country. And so with easy tumors, they get great results. With more difficult tumors, then there's a higher risk of recurrence. The older I get, the younger the old age people seem to be. But I never discriminate against old age, because I've seen patients who've been left untreated on the assumption they're going to be saved by the bell, and then they survive long enough for all the problems of the untreated tumor, perhaps at a time when they're less fit than they were when their tumor was first detected. So I treat all patients equally, irrespective of age. I think having a disease like ocular melanoma is a shock to the system, especially with lots of reminders, especially with the uncertainty. And all of that is very tiring, from what I've learned from you. A dip tends to occur when patients go home after their treatment, because first they're all geared up to have their treatment, and in hospital they're okay, then they go home and then they relax, and then they get very post-holiday blues kind of thing, from what I hear. And that's why we tend to phone patients when they go home to give them the encouragement they need during that critical time. Well, it's a great pleasure to be here. At the moment, I'm at the stage of my career when I've got a lot to share with everyone, with ophthalmologists and so on, not just from my successes, but also my failures. And the longer you've been at it, the more failures you have to learn from and to share.
I'm conscious that you're pressed for time. There's still quite a few more questions
All right.
here, so I don't know if you want to keep going or if you want me to email you.
Whatever you wish.
It's up to you. It depends
You're the
on how
boss.
long we've got.
Are there lots more questions?
There's another 9 questions.
No.
They just keep coming.
All right. So I think we'll stop there, but I'll be delighted to answer any questions. I've gone a bit over time with the questions. I stopped on time exactly at 4, but I haven't. Anyway, thank you very much. Thank you again.